So welcome everyone to our first talk in the Global Research Leaders Africa series. GRL Africa, or Girl Africa, is a series of research talks from African scholars who are developing and leading exciting public health research programs across the continent. We hope that these talks will introduce NYU faculty and researchers to leading scientific research programs based in Africa, help participants identify opportunities for collaboration with rising researchers, and build stronger and more diverse research networks linking public health experts based in Africa to those based at NYU. So today it is my pleasure to introduce our first speaker, Dr. Patricia Turimumahoro. Dr. Turimumahoro is a medical doctor and implementation scientist whose research focuses on uptake of TB services in Uganda. She received her medical degree from Makerere University in Kampala, Uganda, her MPH from the University of California at Berkeley, and completed a Global Health Equity Scholars postdoctoral fellowship at Yale University. Dr. Turimumahoro is based at the Uganda Tuberculosis Implementation Research Consortium, or UTURC, as we call it, in Kampala, Uganda. At UTURC, she serves as a researcher and study coordinator for NIH-supported trials of interventions to improve delivery of TB contact investigation and outcomes for HIV, including leading the cost-effectiveness analysis for a recently completed stepped wedge cluster randomized trial that she's going to tell us about today. On a slightly more personal note, I've had the pleasure of knowing Dr. Turimumahoro since 2016, which is when I first started working with UTURC. We share mentors, Dr. Achilles Katamba and Dr. Luke Davis, who were the PIs of this trial, and we grew up together as early career researchers. So this feels a little bit like getting to introduce my academic sister, and I'm really looking forward to hearing more about this cost-effectiveness analysis. So with that, I will turn the webinar over to Dr. Turimumahoro. Thank you for joining us today, and the Zoom is all yours.
Thank you very much, Mary, and greetings to you all. So today I will speak about the incremental cost and cost effectiveness of a user-centered contact investigation compared to the standard of care contact investigation in Uganda. But before I start my talk, I would like to first acknowledge the institutions I've worked with and the exceptional team that I'm a part of. Walimu World Alliance for Lung and Intensive Care Medicine in Uganda is our host organization in Uganda and my employer. They do a wonderful job administratively. I would also like to acknowledge our principal investigators, Professor Luke Davis, Mary Armstrong, and Achilles Katamba at Yale, NYU, and Makerere, respectively, who have been visionary and involved mentors and research leaders. The branded collaboration that defines our work is Uganda TB Implementation Research Consortium. I'll talk a little bit about myself. I am a proud Ugandan-born and trained primary care physician who has been in clinical practice for about 10 years. 9 years ago, I met Achilles Katamba, who introduced me to research and remains a close mentor and friend. So through him, I have expanded my collaborations and have led multiple social behavior experiments in the field of TB implementation research in Uganda. While I am innately passionate about improving others' health and well-being, it's the Masters in Public Health that I did at UC Berkeley that really changed my perspective on health. And it has seen me since dedicate my life and career to developing public health programs that effectively translate synthesized evidence into practical implementation. So armed with skills in epidemiology and economics of population health from my postgraduate training degree and field implementation science skills, I have set out on a journey to do my best, not only to develop my own skills, but also to share these skills and inform decision-making. And today is part of that journey. And I want to thank you, Mary, for the invitation. So as she said, I just completed a Global Health Equity Scholars postdoctoral program at Yale and Macquarie University. And I also thought I'd just show you this beautiful aerial view of a small town called Kisoro in Uganda, where I grew up. By the end of my talk today, I hope that we can get a sense of the global and Uganda national TB disease burden and the emerging role of active case finding through TB contact investigation. I would also discuss the challenges we've encountered trying to put contact investigation into practice and how we developed and evaluated this user-centered contact investigation strategy and what it means economically. TB is both preventable and curable, and yet in 2023, approximately 3.1 million cases were not diagnosed. In Uganda alone, there were about 31,000 undiagnosed cases. The key drivers of this persistent epidemic includes delayed diagnosis, a very high prevalence in our setting, malnutrition, and poverty. As you can see on this map, Uganda is over here. Uganda is highlighted in a darker shade of green, and it represents TB incidence rates between 100 and 300 per 100,000 population per year. This high burden underscores the urgency of improving our response. Unfortunately, up to 50% of all TB patients face catastrophic healthcare expenditures. And most of these, or more than half of these costs, are incurred before diagnosis. This amplifies the critical need for early diagnosis and interventions that can reduce this financial burden to patients. In 2021, WHO endorsed TB contact investigation as an evidence-based practice to find, treat, and prevent TB. Uganda's national TB program quickly took this up and adopted the recommendation. And by 2019, we had a national guideline on how to do contact investigation. But there are still many gaps that exist in its uptake, its reach, its effectiveness, and efficiency, especially in the real world. Mary analyzed the TB contact investigation cascade, which you can see over here on the right bottom corner, and found that only 20% of contacts that have TB symptoms completed the TB evaluation process. Challenges such as dissatisfaction with health services, travel time, and cost of an otherwise healthy patient, lack of knowledge about TB, were described by Irene as the barriers to contact investigation. And despite Uganda's investment in TB contact investigation over the years, you can see once again, Uganda is in gray over here. We have only managed to stabilize TB incidence between 2015 and 2023, which indicates that we may not reach the NTB target. As such, there's a need for very bold approaches to active case finding, complemented by accurate, valid, and reliable point-of-care diagnostics and cost-effective prevention strategies to realize those end TB goals. So, as a team, we used human-centered design, which we may be familiar with, to develop a user-centered contact investigation. Human-centered contact investigation is a user-centric co-design process that emphasizes building empathy with the end user. It embraces ambiguity and rapidly iterates and optimizes optimizes design ideas for the end user. One of my greatest lessons from the design process was that for our index patient, the healthcare system seems to layer demands, as you can see up here, when our patients are at their emotional low. And after TB diagnosis, for the contacts, their responsibility tends to increase, and this diminishes their health-seeking behavior. As such, interventions to enable index patients to handle the burden of TB diagnosis and help contacts navigate the healthcare system were the cornerstones of this user-centered intervention that we developed. While these bold user-centered contact investigation strategies may be effective, they can potentially be unaffordable. And the objective of my economic evaluation was to understand what the total cost of the user-centered care is, what the cost of standard of care is, what the effectiveness of user-centered care is, and the effectiveness of standard care is, and also to project the incremental cost effectiveness ratio of standard of care compared to user-centered care. We embedded our economic evaluation in a step-to-edge cluster randomized trial. This happened at 12 TB management units in Uganda, and we enrolled consecutive index patients and their contacts. We defined a contact as someone who spent greater than 1 day or night under the same roof as someone who was diagnosed with TB. And the standard of care is illustrated at the top of this process flow diagram on the right. A patient is diagnosed, we identify who their contacts are, we visit their homes and screen their contacts, and then we evaluate their contacts at home or at the clinic for TB and give them a diagnosis or outcome of that evaluation. The user-centered strategy maintained this process flow from the standard of care, and it only added what we call birungo, also known as spices, to make the process more engaging for the users. The first element of the user-centered strategy was Turimumahoro. Turimumahoro means we are together with you. This brand was designed to inspire trust and confidence and safety to the patients. We also used simple visual materials to share the facts about TB simply but also discreetly, and to dispel any misinformation, and also enable index patients have tough conversations with their contacts about screening for TB. We facilitated transportation of patients, providers, and their contacts through a community health rider program to make it easy for patients to visit a facility and help relieve community health workers of the burden of navigating transportation. Lastly, we developed a community of practice among healthcare providers to help them troubleshoot challenges, provide accountability to each other, and review patient tracking reports to improve outcomes of their patients. For our economic evaluation, we used an empirical, mixed ingredients-based and expenditure-based technique to evaluate the costs of Turimumahoro at all these 12 sites. We sampled 6 clinics for time and motion studies and facility cost surveys. In the ingredients-based approach, we collected information on quantities and prices used to value all the resources that were needed. While in the expenditure approach, we used the total expenditure from budgets or expense reports from the Ministry of Health and project expenditure logs. Here on the right of this slide, you can see the ingredient items that were considered and how they were broadly categorized, and that we'll review in the results. So we first started by estimating costs in UGX. We converted them to US dollars using the World Bank exchange rate. We adjusted for inflation using the World Bank GDP deflator consumer price index. And then we aggregated these costs into broad analytic scenarios. One was the trial scenario, and the second was a 5-year period scenario. In the trial period scenario, we aggregated the ingredient costs for comparison purposes. We estimated and compared costs over a 12-month calendar period for each site. We assumed that the intervention activities and funding would cease after this period. In the 5-year period, we projected costs over 5 years without any additional capital expenses. The trial period costs were the sum of all the ingredients, and each cost item was a product of the unit estimate multiplied by the amount utilized. This diagram shows you the items that we costed and how they were measured, quantified, and monetized. And the blue boxes you see over here contain items that we only costed at 6 sites, while the green boxes represent the items where we had empirical data at all the 12 sites. So between March 2022 and October 2023, we conducted a step-to-edge cluster randomized trial, and the order of transition from the standard of care contact investigation to user-centered contact investigation is demonstrated in the Gantt chart in the left corner over here. And overall, at all 12 sites, we enrolled 840 persons with TB during the standard of care and 997 persons with TB during the user-centered contact investigation. We had 2,874 contacts during standard of care, 5,761 contacts during user-centered care. 67 contacts were diagnosed with TB during standard of care, contact investigation, and 187 during user-centered care. This figure on the right just demonstrates the enrollment of persons with TB, their contacts, and contacts diagnosed with TB. Overall, you can see that as we transitioned into the user-centered care, we had more contacts enrolled and more contacts diagnosed with TB. The annual weighted mean cost of the intervention at one clinic was approximately $24,000, as you can see over here. And the weighted standard deviation, $15,000. The wide variation is primarily from service volume at the different clinics, while the total cost of intervention was approximately $250,000 at all 12 clinics for 1 year. If the intervention lasted 12 years, the total cost of the intervention would be $1.7 million. Consumables accounted for approximately half of the total costs at all these 12 clinics across the board in all scenarios. This table over here shows the total cost of the intervention compared to the standard of care, as was observed in the trial-specific and annual 5-year scenarios at the clinic. Overall, the intervention costs, you can see, were over 2 times more than the standard of care, with consumables, personnel, and training costs being the key cost drivers of the incremental costs of the intervention compared to the standard of care. This stacked plot mainly shows which ingredient items were the key cost drivers of the incremental cost. As you can predict, this dark gray area represents medication costs and was one of the key drivers of the incremental costs of the intervention, because we had more people that were initiated on TB treatment and TB preventive therapy with the intervention. The light blue area, which is also a very significant cost, incremental cost, is the cost of the community health riders. And on the right, you can see a picture of our community health rider team at one of the smallest health units that was part of our trial. The costs for the riders at this unit incidentally were higher because it's rural and it generally took, and they generally covered longer distances, taking more person days to complete contacts for a single index patient. The cost of support supervision, which you can see here, is dark brown, diminished with the intervention. And we attribute this to the introduction of the community of practice, where health workers at a single facility were able to monitor their own progress on performance. This table shows the incremental cost effectiveness by analytics scenario. And the incremental cost of the user-centered strategy was approximately $150,000 in the trial period and $700,000 in the 5-year period. We observed an incremental cost, an incremental effectiveness of 329 additional contacts detected with TB in the trial period and 12,444 in the 5-year scenario. The associated incremental cost effectiveness ratio for the trial period was $604 to identify one additional contact with TB and initiate them on treatment, which was slightly more cost effective if implemented over 5 years, at $507 per additional case of TB detected and treated for TB compared to the standard of care. One limitation, though, of this estimate is that because we used a step-to-edge design, we had to standardize costs and outcomes for each scenario over time. And one key assumption we made is that the incidence remained constant over time. The user-centered was more expensive, but it was also more effective. An ISA of 507 additional contact detected and started on treatment is quite comparable to other active case finding strategies that are in higher income countries. In India, Azuman estimated the ISA to be $1,200, in China, $3,800, and in South Africa, $9,400 to identify an additional case of TB and initiate them on treatment. If we assumed that each case detected averted 1.9 DALYs, a figure that I pricked from ISA predictions of DALY averted from Azuman et al., indicates that this intervention ISA value is $300 per DALY averted, which is within the GDP per capita threshold for DAL is averted, considering Uganda's GDP, assuming that we have ×3 GDP threshold. I would strongly recommend this intervention to similar income settings and operational settings, as the intervention only requires simple, available adaptations to what WHO and yet improves reach and access by the people who need that service. I would like to acknowledge the team that I worked with, that I have already introduced, the people at the Ministry of Health Uganda that supported this study, the team at Johns Hopkins that's part of this cost effectiveness analysis, and also the funding I received from the Global Health Equity Scholars Program to conduct this research. I would also like to acknowledge IDEO.org that was part of the development of this user-centered intervention. We'd also like to thank our administrative team at Walimu. Thank you very much, and over to you, Mary.
Thank you, Patricia. So folks in the webinar, if you have questions or comments, please put them in the Q&A tab down at the bottom. While you're doing that, I actually have two questions. I'm going to ask one because I think I can see something in the chat already, and then I'll go to the group. So one of the things that I always think about with this intervention, this is actually true, I think, across a lot of implementation science studies in low middle income countries, is a lot of effort was spent to design the intervention. And that was an expensive process. It involved a lot of people from your team at UTURK. It involved the IDEO.org team. It involved co-investigators from other universities. And I wondered, how did you think about that for the cost effectiveness analysis, the initial costs of producing the intervention? So that's sort of question number one. And my follow-up question is, do you have ideas for getting initial design costs down? Like as we're developing new and adapting interventions for Uganda, how might you use techniques that you might have learned from the human-centered design process in a way that is maybe more cost-effective for the initial design of the intervention?
I think that's a good question. We didn't consider startup costs for developing a user-centered TB contact investigation strategy. We assumed the intervention was already developed and focused on highlighting what the incremental costs are of just implementing this intervention. Judging from the type of intervention that was developed by IDEO.org, that took into context the setting in which we are working and the people's needs and even the health workers' needs. Very minimal adjustments or adaptations need to be made to such an intervention. And I think just simply implementing this intervention at scale would help us realize return on investment with the human-centered design process and development of the human-centered design process. And from a paper that we developed, we also identified that with thresholds of effectiveness of this type of intervention, even with the design costs put into place, this type of intervention can be cost effective. So yes, it's true, this analysis doesn't take into consideration those startup costs, but focuses more on just the delivery of this intervention, assuming that it is already developed. Thank you.
Thank you. And I think that my colleague has a question to ask live.
Hi, I do. Thanks for that presentation. That was great. I'm curious to hear your thoughts. I think you often hear from one often hears from policymakers that sort of cost and cost effectiveness is a really important part of the decision about whether to adopt new practices into policy and guidelines. But it's clearly not the only thing. Otherwise, every cost-effective intervention would be institutionalized, right? And so I'm curious to hear your thoughts and how the team is thinking about what other kinds of evidence might be influential for turning, user-centered contact tracing into formalized policy and guideline in Uganda. Thanks.
Yeah, thank you. I think that's a good question as well. This project was done by a number of researchers, and we have not only described just the cost effectiveness of this intervention. One of the papers that will be coming out of this will be the main trial paper that just simply describes the effectiveness of this intervention. We also have fidelity studies that are looking at to what extent health workers and patients actually adapted these things that we are proposing. And then I think many more will come out trying to just describe the context in which we think this strategy works. And we hope to bring this all to the table as a complete package to the policymakers for consideration as they make their decisions, supported not just by cost effectiveness metrics, but health impact, usability by health workers, by community health riders. And I'm sure you'll be seeing a lot more on this paper. But comprehensive evidence has been generated from this trial that I think, in my opinion, is very convincing, and I would strongly recommend to policymakers, including those ones that often fund these types of interventions, not just by the Uganda, but what we call implementing partners in Uganda. Yeah, thank you very much for that question.
Yeah, thank you. So we have a question from the chat. It's a two-part question. The first question is, how did the intervention affect patient costs? And is this something that policymakers commonly consider in evaluating TB interventions in Uganda? Or rather, the question is actually, is this something that policymakers commonly consider in evaluating TB interventions? Full stop.
Yes, so patient costs are very important. You can see in my introduction, I talked about how many patients who are seeking TB end up with catastrophic expenditures, having to sell a cow, having to sell part of their property, having to take loans in order to take to even just get a diagnosis. And like I said, 50% of these expenditures are even before they are diagnosed. So generally, the types of public health policies that are being proposed, which include multiple active case finding strategies, like contact investigation, which I have talked about, are supposed to shorten the time between onset of symptoms and the time a person is diagnosed. And this definitely affects and is an important part of public policy making in Uganda. However, for this particular evaluation, we did not consider any patient because of restrained resources, but it is an important part of costing, and it is something that's considered as these types of health policy decisions are made, and could actually be a follow-up as maybe we get to see this type of intervention implemented in Uganda. We could look at patient costs and what patients' costs are averted, and things like that. So it's something important, I think. Thank you very much for that question.
Yeah, and thinking through the intervention components, it does seem like several of them would directly affect patient costs, especially the community health riders, being able to bring them in for evaluation, transporting sputum samples, things like that. So I have that actually made me think about another question that is also related to these sort of what we might call halo effects of the intervention. So it's not necessarily directly reflected in your cost effectiveness analysis, but in a broader sense, it might affect the total costs associated with an intervention and the total costs that intervention manages to mitigate. You mentioned that the cost per new TB patient identified, initiated, and treatment was $604. And then that corresponded to $300 per disability adjusted life year. So we might think of this as like buying disability adjusted life years for these TB affected households at $300 per dolly. But it doesn't seem like that takes into account the transmission dynamics of TB. So every time you are able to identify someone who is affected by TB and initiate them on treatment, then you're potentially averting another new TB infection in that household, at their workplace, in their inner circle. I know that it's not what you did in this analysis, and forgive me, I'm not very sophisticated when it comes to cost effectiveness analyses, but are you aware of other studies that have done that? Or like, is there a way that you could take into account the costs averted by identifying someone affected by TB earlier rather than later?
Yeah, I think that's a very interesting. It's actually something we would like to report, probably a specific figure on cases averted through early diagnosis. But we can get a rough approximation, very similar to what we've done with the DALIs in this example. I have not fully read the literature to look for those. There are quite a number of studies that have tried to predict DALIs averted through early diagnosis. And I'm also trying to find literature that predicts also the cases averted through early diagnosis. And I think it's something worth mentioning in the discussion section of this paper that we're going to write up, and can also give an approximation, which is I think informed by good empirical data, putting together good empirical data and model estimates, to at least estimate those spillover effects of such an intervention. It will not be the primary outcome of this study, but an outcome that is worth mentioning. I agree with you.
Thank you. All right, we have one more question from the chat. Even cost-effective interventions can ultimately be unaffordable. Have you estimated the total cost of implementing this at scale? And if so, how does it compare to the cost of other programs?
Yeah, I think I really focused on just a few things in this presentation, but we are going to, part of what I'm doing is a sensitivity analysis to identify affordability, but also still cost effectiveness of this intervention at scale with an increased number of clinics, an increased number of patients, and so on and so forth. And we're using probabilistic sensitivity analysis techniques to understand this. We'll also do a one-way sensitivity analysis and a multi-way sensitivity analysis. And this will be part of what we'll publish in our literature. Although that's still work in progress, I think it's an important aspect. Just to mention this, we'll also be looking at the willingness to pay thresholds and the probability of cost effectiveness within our setting. Yeah, thank you for pointing that out.
Great, thank you. I'm not seeing any other questions in the chat. So I think that we're about ready to wrap up, but I wanted to thank you so much for joining us today. And I wanted to ask you the question that I always ask at the end of interviews, which is, was there a question that wasn't asked today that you thought we were going to ask you, or that you wish we had asked you? Oh, it might have frozen. Can you hear me?
I think I didn't hear parts of it.
Oh, sorry. So I was asking if there was a question that you thought that the audience was going to ask today that we didn't ask. I can see that your video keeps freezing.
Yeah, yes, you're right. My network isn't so great. And yes, I have only had parts of the question. If you could just say that once again.
It's a non-question question. I was asking if there was a question that you anticipated us asking today
Again,
that we did
I'm
not
sorry.
ask. Oh, I think we've lost you. Well, I will throw this in the chat, but thank you so much for a great presentation. I see that Dr. Katamba is putting something in the chat for you as well.
Well,
Thank
you of our estimate.
you. The lag has come just in time for the end. So we're just thanking you for joining us today. And I'm gonna turn it over to my colleague, Karina, to share with us a little bit about future talks in this series.
Yeah, thanks, Mary. Thanks, folks, for joining us. So as mentioned at the outset, this is the first in a series of these seminars throughout the year. So just wanted to share the next few. So the next one and the last one in 2024 is on November 25th. And we have the pleasure of having Daima Bukini speak with us. She's an expert in the ethics of advanced treatments and therapies in the African context, particularly around sickle cell disease. And so really excited to have her for a presentation on bioethics. That's on November 25th. And then we take a pause for winter break here, and then we're back in February. The first will be on February 10th of 2025. Happy to share the list of all the upcoming talks if folks haven't received it from us. But again, Patricia, it was so great to have you speak with us and kick off this series. Thank you for answering our questions. And yeah, we look forward to seeing folks hopefully on November 25th for Dr. Bocchini's talk. Thanks, everyone.
Thanks, everybody.
Thank you.